Hi, this is Kristen at UT Southwestern. Thanks for joining us for our chat on depression and mental health with Dr. Robert Kinney. Dr. Kinney leads UT Southwestern's Mood Disorders Network and focuses on understanding the neurobiology and psychology of depression and mood disorders. So we want to thank, of course, the Center for Depression Research and Clinical Care and the O'Donnell Brain Institute for their support. Thank you for joining us.
Thanks. Glad to be here.
Absolutely. We have a couple ground rules in that, we want to make sure that you like the conversation, you share it. If you have a question, please ask it in the comment field. We're going to take as many as we can get to. And also be sure not to ask a specific patient question. We can talk in generalities, but we don't want to get into specific issues about anyone's health. So to get started, since this is about depression and mental health, how can somebody tell if they're feeling the blues, or if it's a case where they need to make that call and call a psychologist, a psychiatrist, somebody with that level of expertise?
So, are we talking about someone themselves?
Yes, someone themselves.
Okay. So I'm wondering if I have depression, or if I'm just having some run-of-the-mill.
Yeah, if you're just sad or you're blue. I know everybody seems to have the blues every once in a while.
Mm-hmm. So I think the biggest there are lots of big differences between sadness and depression, but the things to be aware of are, for one, that it's having some sort of impact on your ability to function in the world. So that could be your social functioning, maybe you're not getting out there and meeting with people, or your occupational functioning. So maybe it's difficult to be at work or go to school. To dive into this, there are 9 major symptoms of major depressive disorder. There are a couple different depressive diagnoses, but if we're talking about major depressive disorder, there are 9 major symptoms. In order to have a diagnosis of major depressive disorder, you would have 5 of the 9 symptoms. Backing off from that, you have to have 2 symptoms of depression to meet diagnostic criteria before you have to have 5. So you can have any 5 of the 9, but one of the 2 symptoms has to be present. The first one is a sad mood. That can be sadness, that can be irritability, that can be crankiness. This is either by your own awareness. If you're an adult, oftentimes we can have that awareness. If we're a kiddo, sometimes it can be by the report of other people. So maybe that's a teacher or a parent. So that's one of the anchor symptoms that would have to be in place. The other anchor symptom is what's referred to as anhedonia. Anhedonia is a lack of interest in activities that we previously felt were pleasurable.
Gotcha. So if you previously liked going roller skating, yes, that is a thing.
Right.
And you suddenly decide, I don't want to do that anymore, that should be a concern.
Right. Not necessarily a concern if you don't have the other symptoms. Sometimes we just lose interest in activities that we previously liked. I used to like certain TV shows that now I no longer like, that I won't share because it's embarrassing. But beyond that, there are 7 other symptoms. One would be if you have significant weight change, so 5%. But this is if you're not trying. So you're not trying to lose weight. 5% in either direction. Most of these symptoms exist on a continuum. So it's either significant weight change or a change in appetite. The change in appetite can be in either direction. Like I said, it's on a continuum. So that can be either I'm very, very hungry, I'm eating a ton of food, or I'm not hungry at all. In pediatric populations, this can be qualitatively different. This can be an interest in carby foods, so sweets and breads and candies and things like that. Another symptom is a change in sleep habits. So this is either referred to as either hypo or hypersomnia. That's sleeping too much or sleeping too little. Usually the hypersomnia looks like waking up in the middle of the night. I have a cheat sheet because I'm on camera and I thought I might get nervous, which happens. Changes in motor activity is another symptom, which is either feeling like you're stuck. Can I say molasses anymore? Does anybody know what that is? Feeling like you're stuck in molasses, or feeling very, very restless, like you're almost
interesting.
jittery. Loss of energy, so fatigue, tiredness.
Okay.
Difficulty with concentration's another symptom.
I've heard that. Okay.
And feelings of guilt or worthlessness. This one exists on a continuum too. Feeling like I'm a burden to my family that's often reported. Yeah.
Okay.
All the way up to some differently concerning symptoms that might be present. The other symptom that can come up is, and again this exists on a continuum, feelings of suicidality. So this is from something like the world might be better off if I weren't here, or my family might be better off, or I wonder what it's like not to wake up.
Yeah.
All the way up to very concerning symptoms.
Okay.
But those are the 9 symptoms of that. You would have to have 5 to have. And you don't have to diagnose yourself. We actually ask that you don't diagnose yourself. But if you're feeling like you're having some of these symptoms for around 2 weeks or over 2 weeks, it would be important to contact either a medical or a mental health professional.
Okay, great way to start off. So we have a question here from Muhib, who is in Afghanistan. Welcome. We don't have many people from Afghanistan tuning in. And this relates to those symptoms you were talking about, that you have to have 5. His question is, how long does clinical depression exist? Is there a time period? How do you deal with that?
How long does it exist?
Yeah, is there, if you have it longer than 3 weeks, is that an issue?
Chronic depression is definitely something that is real, and it is an issue. There are some other diagnoses that you can do end up spilling over into. So said another way is, if you have major depressive disorder, then if that lasts for over 2 years, if you are in one long depressive state, and then you can have actually one fewer symptom and still have this other disorder I'm about to mention. It used to be called dysthymia, now it's referred to as pervasive depressive disorder.
Okay.
And that's a long-standing depressive episode that doesn't really remit. Dialing back from that though, depressive episodes can vary in length. They can go from just 2 weeks, that's the minimum threshold.
That is the minimum, okay.
Yeah, so it's a 2-week minimum threshold, and then from there they can last for any duration.
Okay.
It's important though that if you are struggling with long-standing depression, to have multiple trials.
Okay.
There are a lot of different depression treatments out there. There are pharmacological treatments, so taking medication. There are treatments that don't necessarily engage another professional. Like I know that you had Chad Rothworth on here.
We did, talking about exercise and depression.
Exercise can be a great treatment for depression, and also psychotherapy. Those are some of the major treatments of depression, but within that there are many different approaches. So if you have long-standing depression, trying things out to find a good fit for you is important.
Sounds good. Well, I know I want to get to the research in a little bit, but we do have a couple of questions here, and one of them is from Heather. Her question is, can you speak at all to the correlation between addiction and depression? Is that something that you have any research going on here related to?
We do have several faculty members who are interested in both fields. The correlation between addiction and depression. So they are both mental health issues, and sometimes it's important to figure out which disorder is the prevailing disorder. So which is the primary diagnosis is how we would say it as professionals. And the reason that that's important is to figure out what treatment strategy to take first, because you want to tackle the first disorder and the second disorder. And oftentimes someone can have depression and be self-medicating with with a substance.
Gotcha. Okay, that makes sense. A good question, Heather.
That's a good question, yeah.
Yeah. So here's one from Lori, and this is one that I've also heard a lot of. She's hearing lots of stories about younger adults talking about anxiety. They're stressed, they're anxious. I know anxiety is often tied to depression. Her question is, are you seeing more of this, and what are the best treatment options for anxiety?
So if I heard the question right, it's are the prevalence rates of anxiety going up for young adults?
Yes.
And what are the best treatments for anxiety?
Yes, that's exactly it.
Okay. I think that there are lots of different ways to go with the response to this question, but whether it be that we have better tracking now or that prevalence rates are actually going up, it is important to be aware that more people are reporting depression and anxiety, and I think that the best thing that we can do is listen and validate and be glad that people are letting us know that they're struggling. Anxiety treatments actually tend to be very similar to depression treatments, and sometimes depression can manifest as anxiety. There's if you think of it kind of like two circles that have a lot of overlap, that would be where the depression anxiety realm often is. There's a little bit that's not, and there's a little bit that's not in its depression, and there's a little bit that's not in its pure anxiety. But the best treatments, again, there are so many things that can be done. Things like exercising, things like taking yoga or attending a mindfulness group where you can really immerse yourself in something and learn how to use that skill outside of the group can be beneficial for a lot of people. I think stress management is a skill that can be taught, and once we gain those skills, it can be very beneficial.
Okay, good to know. Great question. Thanks for bringing it up. Now we're going to get back to depression here. We've got a question from Charlene, and this is also related to kids and teens. Her question is, are there ways to ward off depression in kids and teens who face lots of social pressure this day? So related to that, are there things that are different that kids should be doing than adults?
Yeah, I think that definitely, our lives as adults are very structured. I think that it's important to have unstructured time for kids, if I'm getting the gist of the question, so that they can be free play. They can be free to engage in the activities that might build a sense of what's often referred to as self-efficacy. So a sense of achievement, a sense of empowerment.
So they can be free to be kids.
Yeah. Okay. I think also warding, I think it's a fine line. We try to ward off depression, which I think is important. We try to know what builds resilience, which we have a long-term study going on right now that's trying to get at what resilience is. So it's important to try to ward these things off. But on the other hand, once we've got an awareness that there's depression or anxiety at play, I think that early intervention is key, and getting people hooked up with the supports that they need as quickly as possible, and validating that something like 1 in 5 teens struggles with significant emotional distress.
1 in 5?
Yeah, so they're not alone, and validating that they're not alone is important.
Good question, Shirley.
Yeah.
So related to that, we talked about this earlier, but what advice do you offer to patients, whether they're adults or teens, when they're in a depressive state?
What advice do I offer to teens or to patients when they're in a depressive state? I think it depends. It depends on how severe the depressive state is, but I think it's important to let them know that there is hope. One of the reason depression is a difficult disorder to treat is because people feel like they're a burden. They feel like they're not good enough, and that they're a cost to themselves, they're a cost to their family, and they might be a cost to society. So letting them know that they're worth it, and that I am so glad that they're willing to reach out and seek help for their depression and figure out that they are not alone. And oftentimes that knowledge can be helpful for people.
Good, very good question. So we're actually halfway through our chat already. So keep those questions coming. There are some great ones. I'm really enjoying this. So we've got another question from Heather, and some people clearly need professional help for their depression and anxiety. But what if someone doesn't believe in therapy or medication? What are some good ways to attempt to persuade someone that they need help or they need to seek options? That's a tough one.
That is a tough question. So, speaking in generalities, I think that oftentimes persuading someone doesn't. Social psychology teaches us that trying to persuade someone often doesn't work directly. being a support to someone and asking questions and letting people find their own answers can be really helpful. So someone not believing in therapy, it might be helpful for them to be aware that therapy has worked for other people, or that there are lots of options out there. And sometimes medications that are prescribed for that have an impact on depression are often prescribed for other things. So they're I guess not believing in therapy and not believing in medication is something that I come across a lot, but it's a difficult process. And I would say if you're friends with that person, just being a support for them and reminding them gently when there's an opportunity that there's help out there if they want to access it.
Okay, good question. So we have one here that's related to that, and this is different though. It's from Amy. And her question is, if someone is currently on medication for depression and anxiety, what are the things they should consider before working with their doctor to try to stop taking the medication?
This happens all the time. So it depends on, I feel like I'm saying that a lot, and that's the one constant in psychiatry and psychology, that it all depends right now. If you're on a medication and you feel like it's not being efficacious, it depends on how long you've been on that treatment. These medications are, so you take Tylenol and your headache goes away.
Yeah,
right?
good, usually.
Yeah, right, hopefully, right. And you wouldn't take it again if it wasn't working. Or you might just take more of it. It's different with the antidepressant medications. What you want to do is work directly with your doctor. Sometimes it takes about 4 weeks for a therapeutic dose to build up. These medications build up in your system. So sometimes you won't even change for maybe 6 weeks if you're having a minimal effect. If it's working a little bit, you aren't going to change for 6 weeks. If your doctor is resistant to change and you feel like you need a change though, maybe it's something that you and your doctor just aren't matching up and it's time to find another opinion. That's okay. One of the best indicators of treatment success with mental health disorders is goodness of fit with you and your doctor. It might also be time to add an adjunctive medication. It might also be time to add therapy. So there are lots of different things that can be done.
Okay, that's good to know. Great question. So we have a couple more here. These are great. We are doing really well here. We have one from Amy Allen. And she asks, have you tried essential oils with anyone or only pharmaceutical medications? So larger question, are there kind of some holistic things out there that work?
So that's a difficult question to answer, only because yes, there is some efficacy out there for things like St. John's wort. I'll come back to St. John's wort, but the other part of this answer is if you find something that helps you, remember I mentioned mindfulness, if you find something that helps you relax and it helps you be present, then most definitely an essential oil would work for you, right?
Okay.
It helps you improve, but I'm talking about essential oils much like I would be talking about reading a book or listening to your favorite music. These are things that if you value them in your life and you have not been engaging in them and they help you improve, that's wonderful. The thing that's difficult about homeopathic remedies, so remedies that are non-medication and non-psychotherapy, is that there's limited research on them. So they might work. We just don't know. We know that St. John's wort works, but there are major side effects of that can, especially if you're taking other medications, including birth controls, they can make your other medications not work.
Gotcha. So that's something that you definitely want to tell your physician that here are all of the things that I'm taking before progressing at all.
Right. Because they are non-medications, but they do have an impact.
Okay, good to know. So great question.
Yeah, great question.
Here's one from Carter, and I think a lot of people ask this. If you are feeling depressed, it's gone beyond 2 weeks. What is the best way to go about finding a professional for treatment? Do you ask your friends? Do you go online? What would you recommend?
That is a good question, Carter. The best way depends. So do you ask your friends? Do you go online? I would say yes. You find out if there are other people that have engaged with a professional provider. I'd say asking your primary care physician. Oftentimes your primary care physician can be a great frontline treatment. They can provide services or point you in the right direction, because they refer a lot to a lot of different people.
Right.
The other thing is to be aware of is that if you feel like you have depression and you are wanting to engage with a mental health professional, your mental health professional, whether it be a psychiatrist, a psychologist, a social worker, a licensed marriage and family therapist, or a counselor, they're engaged in, they're very much invested in helping you feel better. So they will not take it personally if you want another provider. They'll actually help you find another provider. So getting in touch with a provider and talking with that provider about what you need can be very helpful.
Good to know. So this is another really good question. It's a good follow-up to that, and it's another question from Charlene. And the question is this: though well-meaning, what are some things not to say to people going through a depressive state?
What are some things not to say?
Yeah.
Well, I think that relationships are all about rupture and repair. So if you have a misstep in things that you say to someone who that is struggling with a depressive episode, it's important to call that out into the room and talk about that with them and say, this is something that I'm here with you to work through, and I think I said something that may have hurt your feelings, or I think I said something that may not have been helpful. So it's okay to say the wrong thing.
Okay.
Beyond that, though, I think some well-meaning things that people say are, you do this all the time, or just get out, or just snap out of it, or I think something that would be helpful for all of us is to think about, what would I want to hear if I were feeling this way? And I think often what we want to hear is, I could see how you would feel that way.
Yeah.
Or I can see that you're struggling right now, or just validating people.
I think you're right. That's what I would want to hear.
Mm-hmm.
So going a different direction, we have a question from Lisa, and then I want to get to the research before we run out of time. Lisa's questions: what are your thoughts on TMS as an effective treatment for long-term depression?
So my thoughts, I actually don't know that I have thoughts on it, because I think that the science points us in the direction that it works.
Okay.
So I don't really get to have an opinion. I think that Lisa's clearly someone who knows a little bit about depression and what is often referred to as treatment-resistant depression, or TRD. So this is depression that people have had multiple trials in trying to get some sort of symptom cessation. And TMS is just magnets that are applied to the scalp. There are a couple different ways that TMS can be done, but they're applied to the scalp, and you go to, it's an outpatient procedure. You go to meet with an outpatient provider who, for a limited amount of time, and it's across a couple days for usually about a month, maybe a little bit more. And people find that oftentimes people find that they have symptom reduction. The side effect profile is low, so said another way is that people don't have significant side effects from it. And usually it is reserved for people who have had treatments that have not worked.
Okay. Okay.
So those are my thoughts, Lisa.
that was a good question. There was another individual who asked the same one, so I'm glad you followed up on that, Lisa. Yeah. So here's one from Freen Stefan. Can you talk about depression and the elderly? I know several elderly people that have dealt with depression. Is that common? Is it uncommon? So the base rates of depression in the elderly population are a little bit lower than the base rates of other populations. That is not saying that it's uncommon, though. Depression just happens to be very common. The treatments can be different. I'm not a geriatric expert, but oftentimes there are people who specialize in geriatric psychiatry. So speaking with I don't know if I'm getting at your question, but speaking with your provider, getting you hooked up with one of those specialists would be helpful. Okay, good question here. So we've got time for probably 3 or 4 more questions. We've got one here from Kamar, who looks like maybe a pediatrician, and talks about, let's see, I'm trying to make sure I get this clear. Notice that kids are very vulnerable to depression, how can we prevent this? So I think that sounds like it gets to the resiliency study work that you're doing here. Can you talk about that for a little bit? So they're looking to prevent depression in children.
Preventing depression in children. So we do know a lot about risk factors for depression, and we do know that that resiliency is something that is very real. We're also just trying to figure out how to better develop a model of resiliency. So we do have a longitudinal study going on at the center. It's one of the first of its kind that is enrolling. Currently, our number at the Depression Center is 214-648-HELP.
Yes, yes.
214-648-HELP.
We'll share that in the feed, the number for that.
Yeah, and in this study, we're enrolling kids and young adults between the age of 10 and 24 that do not have a depressive diagnosis. And the aim of this is to better assess biological, social, demographic, and psychological factors that contribute to, that are antecedents, that are triggers for depression.
Interesting.
And also triggers for resilience.
Interesting. And so what is that trial called?
This is called the RAD study.
Okay, the RAD study. Okay.
So it's not a clinical trial. It's a long-term observational study. We're tracking people across time. It's a very exciting, very cool study.
Interesting. So how does one get involved in that, and what is the time requirement?
So how does one get involved in it? Call 214-648
HELP.
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 HELP. Yeah,
Okay.
214-648-HELP. And the time requirement, we can be flexible with that. We work around school, we work around other commitments. We're open on the weekends and we're open in evenings. So if you have an interest in being part of this study, we can most definitely help it happen. And we have if you're interested in getting involved in depression research and you have a depression diagnosis or a related diagnosis, we have a mirror study that is called the D2K study. That study we're enrolling people from the age of 10 all the way up through adulthood, and we're doing the same thing. We're getting at the biological factors, the social factors, and the psychological factors to better understand. I think in 10 years, if we're having this conversation, hopefully we will be.
Hopefully, yeah.
We'll know a lot more about depression, and people will refer to it like the Framingham studies with heart disease.
That would be amazing. So we've got time for 2 more questions. I'm going to take one here from Pam. It's about TMS therapy. She says, after TMS therapy, if you've had positive results, how long should those results last? And what's the expectation for the time?
So people end up needing boosters oftentimes. So there's still ongoing research, and we have a treatment resistance study going on right now that you call the same number and to get enrolled in it. But the results can vary widely. Oftentimes, the more difficult case of depression we have, the more likely it is that we're going to relapse, and we'll relapse sooner. So the results are highly variable.
Okay, good question. Good to know. So we are out of time. It's 30 minutes. It flew by.
Yeah, because I talk a lot.
No way. Let me see. Do we have one more question that just came through? No, we didn't. So anyway, I want to thank you for joining us, Dr.
Thanks for
Kenny.
having me.
It's been a great talk. Thank you for all of the questions. As usual, this will be available on our Facebook page, and we're going to post it on our YouTube channel later today. So if you have friends that are on Facebook, drive them to YouTube. Hopefully you'll share the conversation, and then hopefully you got a lot out of it. It's an important topic. Again, thank you, and have a wonderful day.